first thing that you can say is just that the visual acuity is checked, okay? And then you're done with that. So the next part, you're gonna get into the head, face, and the scalp. So the first part with any portion of exam of a particular body part is just inspection, right? So you're just looking at things. And so what you're inspecting for initially is the scalp and the head. When you're inspecting the scalp, if folks have hair, you need to take your finger, and if you just take like a finger and you start inferiorly and then go upward, that way you can see the scalp underneath their hair as it's falling down. That way you can actually say that you did a decent job of looking at the scalp. Oh, as for him, I can see like a third of his scalp, but I can't really see most of the stuff that's on the top. Right? Because if folks have like seborrheic dermatitis or some sort of infection, they might have some scaling and stuff that's underneath the hair there.
Normocephalic with even hair distribution, no masses, lesions, swelling, scaling, or discoloration.
Yeah, so in that same kind of motion and movement, you're looking at the scalp underneath, and then you need to palpate the scalp as well. And that way you can say that you didn't feel any masses. And so you can kind of go through and then palpate, and that way you've done all that part. The next part you've already sort of done because you've done the hair texture. But the last piece that you haven't done, if you've only palpated the scalp, is you need to palpate the mastoids. So those are going to be the big bony prominences just behind your ears. And that's a big thing that people miss a lot of times. So palpate the mastoids. And then there's one other thing you're palpating, right? Oh, scalp. Yeah, so if you roll through the hair with your fingers, palpate the scalp, and then palpate the mastoids all in one move, and you want to combine the talk or the words for number 4 and number 5, that's fine. And that probably, from a flow standpoint, works a little bit better.
For palpation, hair texture is normal without infestations. Scalp and mastoid are non-tender.
Yeah, I want to foot stomp the mastoid palpation because that is like one of the most common things that people miss early on. Okay, so the next part is palpating the TMJ. So your TMJ is going to be just maybe a couple inches above where the angle of the mandible is. So we're going to come right here, and then we're going to have him open up and close, and then open up a little bit. So open up like halfway, and then move your jaw side to side, and move your jaw front to back. Okay, and then relax. Okay.
TMJ not tender and without swelling, no pain, popping, or locking with range of motion.
All right, so what you need to do is make sure that they're closed, that they open all the way, and then they can close again. You're checking for popping and tenderness there, and your fingers are just right there on the TMJ. And then it's easier if they're not opened all the way to get them to move their jaw around. And so about halfway open, they can move back and forth and then front and back. Okay. So next we're gonna test the motor function of the trigeminal nerve. And so what 2 muscles did we say that we're testing?
Temporalis, mastitis.
Okay, so you can, if your person's head is not too large and your hands are large enough, you can test both muscles at the same time. And so you just put your palm on their cheek where the masseter is, and your fingers up where the temporalis is, and then go ahead and bite down, and then relax. Bite down one more time, and relax. You should be able to feel the muscle tense underneath your fingertips, and then underneath your palms as well.
Cranial nerve 5 intact.
Okay. So the next part is testing cranial nerve 7, so that's all the motor function for your face. And so this is where you're gonna have them do a bunch of different motions. So the first one is go ahead and smile for me, and go ahead and frown. Go ahead and puff out your cheeks, and then relax. Raise your eyebrows, and relax. Close your eyes as tight as you can. Now keep your eyes closed. I'm gonna try to pull your eyelids apart, but don't let me do that. So you have your thumbs just down here on his cheeks, and then you just try to raise them up there, and then go ahead and relax. And then we're gonna have you, that's a, okay.
Cranial nerve 7 intact.
All right. So that is all of the head, face, and scalp examination. So on to the eyes. So again, first thing that we do when we get to a new body part is inspection. So we're gonna inspect the eyes, the brows, the lashes, and the lids. And so just a lot of this stuff, and the reason that we have you say the words is because we can't really tell whether or not you're actually doing the thing that we want you to do, right? And so as you're standing here and you're looking, this is where you're saying the words. And so you're looking at the eyebrows, you're looking at the lashes, you're looking at the eyelids, and you're saying
Noptosis, exophthalmos, edema, periorbital discoloration, or skin lesions.
Okay. So the next part is palpating the lacrimal ducts. So where are those at? Are they more medial? Are they lateral? Medial. So the ducts are medial, and then the glands are going to be lateral, right? Because you have to release the tears up here so that they can fall over your eye and lubricate your eye. And so if you wanted to palpate the glands, you would palpate up over here. But for the ducts, they're going to be medial. And what you want to do is you want to palpate and then try to milk the duct to see if there's any stuff that comes back out towards the medial canthus. And so thumbs here, and you can kind of support their head with your fingers in the back, and a little bit of pressure here, and then milk superior and medial a little bit.
No swelling and no regurgitation.
Okay. So next we have our visual fields. So for this one, you're just going to stand in front of the patient, about an arm's length away from them. So what I'm going to have you do is, without moving your head, I just want you to follow my finger with your eyes, okay? So start centrally, and you're going to move lateral, pause, up, pause, down, back to medial, over to the side, up.
I think this one is
Sorry, you skipped a step.
Oh, did I skip one? Okay.
confrontation. Visual fields by confrontation.
Fishbowl division.
Okay, sorry. All right. So for this one, what you're gonna have them do is you're gonna be a little bit closer. You're gonna have them just look right at your nose, and you're gonna have them close one of their eyes. So go ahead and close your right eye, and then you're gonna close the eye that's on the same side.
I can't close my left eye, so
Okay, this is
I'll
fun.
just do the.
All right. I think we have some patches for you.
Okay.
Seriously. So go ahead and close your right eye, and then you as the provider are gonna close the eye that's on the same side. And then you're gonna take your fingers, and you have to be behind midline when you start. One that's high, one that's low. And then go ahead and tell me when you can see my fingers.
No.
And you go the other way. So, no, sorry, just keep the same eye
Oh, yeah,
closed.
No.
Okay, and then close the other eye. There we go.
No. No.
Okay.
Visual fields are full and equal to examine.
Okay. So then you go to the cardinal directions. So standing in front of them. So about arm's length apart. Go and follow my finger. So this way. And then over here. And here. And then you want to do the lid leg too. And so go up and then back down quickly. So without moving your head. So up and down quickly.
ELMs or extraocular movements intact and equal without nystagmus, no lid lag.
Okay. So the next is near and far convergence. So this one, you want to have your finger about 10 centimeters away from their face. And so if you just kind of do a little shotgun, that's about 10 centimeters. And so here, so my finger's going to be right here. What I want you to do, and you don't have to stand right in front of them, but just stand off to the side just a little bit, is focus on my finger and then focus on the wall behind me, okay? So focus on my finger and focus on the wall. Focus on my finger and focus on the wall, okay? And the reason that you're gonna have to do it twice is, one, the first time you're just trying to see, hey, do their eyes come together and then go apart? But you also need to look to see if their pupils constrict when they come closer and then dilate back out when they go further away. If you stand directly in front of them and do this, look over my shoulder, his eyes will move to one side or the other to try to look over my shoulder. So just be a little bit off center and keep your finger on the center, and it should be a lot easier.
Eyes converge equally and pupils constrict near focus.
Okay. So next we're going to inspect the conjunctiva and the sclera. So for this, you have to be able to see the underside of the eyelids. You're not going to get a great examination on the underside of the upper eyelid because we're not having you guys flip the eyelids, but you need to see the underside of the lower eyelids. What's probably easier is if you just take your thumbs and you go like that, and so you can see the underside, and then so go look up, look down, look back neutral, look to your right, look to your left, look up and to the left, up and to the right, right? And so I was able to see pretty much all of the globe that way. I do have to hold his eyelids up and go ahead and look down to the left, down to the right. By doing that, I know that I've seen everything. You can try, if you want to just open up the lids like this, but you need to be able to see that lower lid if you're doing it that way, okay? A lot of times folks will try to do that, but both the eyelids are still shut and you're like, well, you didn't see everything. Okay.
The way we'd like you guys to do is kind of how I showed yesterday, right? Have the patient pull their lower lids down and then tell them to which direction to move their eyes, okay? And then have them pull their upper eyelids up and then have them do the directions again.
No lesions, injection, icterus, foreign bodies, or edema.
Okay. So next we finally get to use the ophthalmoscope. So we're going to test for pupillary light reaction. So just go ahead and look at the wall behind me. And you're going to come here with your light and you're going to shine it once in one eye. And when that first pass, you're looking at the eye that you're shining the light in. And then you're going to do it again looking at the other pupil. And what you're looking for is constriction when there's light and dilation when it goes away on this side, and then the other eye should match it the same way, okay? And then you just do the same thing on the other side. And it doesn't have to be a really long time. It's a quick back and forth.
Pupils are equal, round, and reactive to light bilaterally.
Okay. So the next one is going to be your Hirschberg. And so what you can do is stand about arm's length from the patient again, and then you're just going to look right at my nose. And what you're doing is you're shining the light, and you're trying to shine the light so that the light is over both of the eyes. And what you're looking for, if you guys can all come up here, is there's a reflection of that light on his eye. And the reflection, like the spot where that reflection is happening, should be in the same location in both eyes. If it's like midline over his pupil on this eye, and then it's on like the lateral aspect of his iris over here, then that means that his eye is probably kicked in a little bit. And so this just helps you see like really subtle differences in alignment of somebody's eyes. Okay? So that's that. And then I need an eye cover. Yeah. Oh, thanks.
Lights
Okay.
coming back on.
So you can do that, and then if you want to, you can continue to use the light and then do the cover uncover, but you don't have to use the light for the cover uncover. Sometimes it's just a little bit smoother to do it that way. So if I had the light here, I'm looking for Hirschsprungs, and then for the cover uncover, what you're doing is it's going to be just a once and then a once, okay? Because what you're doing is you're covering close, you're looking at the eye on the right to make sure that it hasn't moved, and you're going to quickly move this one away. Oh, wow, okay. Maybe it didn't, all right. Convince myself it moved. And then what you're doing is you're really paying attention to the eye that's covered as you're quickly moving it away to see if it kicks back in or kicks out. And so that would be a sign of strabismus. So here, really close to the eye, so it's covered, and it's a quick move away. And you only have to do that once.
No strabismus observed.
The reason that you would want to use the light if you want to is that, again, it's the same purpose for the Hirschsprungs. You can see more subtle movements. All right. So the next is anterior chamber depth. This one's really hard a lot of times for people to get used to, because what you're trying to do is you want this light to be like perfectly perpendicular. So just look straight ahead. Perfectly perpendicular, so that it's cutting across, so that if that shadow happens, you can actually see it. If you're too far this way, the light's coming at an angle where you're not gonna get the shadow. If you're too far back here, it's not really gonna work as well. So you're gonna wanna stand in front of them. The light doesn't have to be out here, it can be pretty close. And you're just looking here to see if you see a shadow. Nope. See a shadow? No. And so you'll know you're pretty good, because if the light is hitting kind of the bridge of their nose, you're probably at about the right depth.
No crescent shadow.
So the next part is the actual fundoscopic exam. So while you do this, you can be saying all the words while you're doing the evaluation part, okay? So you're gonna stand about arm's length from your patient. What you wanna do is you want the eye that's more towards the patient's midline to be the eye that you're using for the exam. So if I'm looking at his right eye and I use my left eye and I come in here like this, we're gonna start making out really quickly. But if I use this eye, I'm just gonna be right at his cheek, okay? So the other things that you need to do is you always need to be bracing. And so it's helpful sometimes to put your hand on the top of their head and then your thumb over their eyebrow, because one, you can kind of open up their eye a little bit more. And then you can use your thumb that's on their head as a guide of, okay, I know how close I am. The other point of contact that you can have is when you hold your ophthalmoscope, you can curl your fingers a little bit. And that way, when you get here, I won't show this right, you can rest your fingers on their cheek. And so that, if your fingers are resting on their cheek and your ophthalmoscope is resting on your thumb, you know that you're close enough, okay? We understand the lights are gonna be on, and so you're probably not gonna be able to see things super well. So some of this is just like doing the dance. But if you're back here and you're telling us what you're seeing in there, we know you can't see in there. If you're up here and you're telling us what you can see, we feel much more confident, right? So kind of curled fingers a little bit, as long as those are touching the cheek, and especially if your ophthalmoscope is close enough that it's touching your thumb on their face, then we know that you're close enough, okay? So what you're gonna do, you're gonna stand here, I'm gonna put this up against my eye, and then the first thing I'm looking for is the red reflex. And so what that's telling me is that I'm at the right angle to go in, okay? So red reflex is present, and then you're gonna come closely. And then while you're doing this, you're saying all the words.
Cornea, anterior chamber, lens, and vitreous are clear and without opacities, haze, or encroachments. Discolor is yellow, margins are sharp, cup to disc ratio is 1:2, AV ratio is 2:3 without nicking or spasms, no hemorrhages or exudates. Have the patient look into the light,
So look towards me.
no lesions on macula.
So you're just saying all that while you're actually there. And then you do the same thing on the other side. You guys can be nice to each other. This bottom part changes how intense the light is. So it's turned all the way this way, it's super bright, and you're gonna burn somebody's retina. Turn it down, it's a lot less, so you're not seeing anything this, but kind of find the happy median so you're not blinding your classmates. So that is all of the first part of the HEE exam. So you do the ophthalmoscope on both sides. Do we have any questions at this point?